All right, welcome to the fourth and final explainer of this series on vestibular rehabilitation therapy. Over our last 3 sessions, the source material has walked us through neuroplasticity, patient selection, and exercise prescription. But today we anchor all of that in hard, defensible data. We're going to dive deep into outcome measurement and progression and look at exactly how the literature proves these interventions actually work in the real world.
Think about it for a second. What really separates a memorable 6-week VRT program from one that a patient just quietly drops? Or, for that matter, from a referral letter that a doctor just skims and instantly files away? Well, it all comes down to a retested baseline. Because honestly, an 18-point drop on the DHI and a 4-point gain on the FGA will absolutely outweigh any flowery, subjective phrase you could ever write in a discharge letter. Your patients want a hard number to validate all their hard work. Referrers want to see objective change. And you, as the clinician, absolutely need objective evidence that the dose you prescribed is actually hitting the mark. So here's our agenda for today. Why retest the baseline, core outcome tools and MCIDs, recognizing clinical plateaus, when to refer onward, and our final vestibular series wrap-up. Section 1. Why retest the baseline? A structured 6-week VRT program isn't static. It is highly dynamic, which means it requires constant measurement. You establish your baseline in week 1 using a really tailored outcome battery. Then, by week 4, you're doing an interim review just to track the trajectory. And then we hit week 6, where you perform a formal retest. This 6-week marker is absolutely crucial. Clinical trial data shows us that structured VRT, when initiated early, achieves age-normal balance and gait by 4 to 6 weeks in roughly 80% of acute unilateral hypofunction patients. So retesting at that 6-week mark gives you that rock-solid, defensible result that drives whatever comes next, whether that's another block of care, transitioning to a maintenance program, or referring them on to a specialist.
Section 2. Core Outcome Tools and MCIDs.
The recommended core set for vestibular physiotherapy brilliantly combines patient-reported handicap measures, balance confidence, objective gait and fall risk metrics. It's a great package, but here's the thing. Tracking these scores is totally meaningless if you don't know the MCID. That's the minimal clinically important difference. This is the exact number of points a score has to change for the patient to actually feel a real functional difference in their everyday life. It is literally what separates true clinical progress from, just statistical noise.
Let's break these numbers down, starting with the Dizziness Handicap Inventory, or DHI. For this one, an 18-point reduction is clinically meaningful. In your typical clinic, you're usually going to see a baseline score of 40 plus when a patient first walks through your door. So when you finally hit that 18-point drop at the 6-week retest, boom, you have objective, undeniable proof that the patient's perceived handicap and overall quality of life have materially improved. Next up is the Activity-Specific Balance Confidence, or ABC scale. This is a game changer for tracking fear avoidance. And remember, avoidance behavior is literally the strongest negative predictor of a successful VRT outcome. On the ABC scale, anytime a score drops under 67%, that flags a serious falls risk. When you retest, you are looking for a 10-point improvement as your clinically meaningful target. Hitting that 10-point jump means your patient is actually getting their confidence back. They're moving their head again, they're engaging in complex environments, and that is exactly what the central nervous system needs to adapt. Now, for dynamic postural control, we lean heavily on the Functional Gait Assessment, or FGA, and the Mini-BESTest. On the FGA, any score under 22 out of 30 is a widely recognized falls risk threshold. For both of these amazing tools, you want to look for an exact 4-point improvement. Nailing that 4-point gain is clinically meaningful and perfectly confirms functional balance progression. And let me tell you, that is particularly vital for ensuring safety and independence in our older vestibular populations. And finally, we have the Motion Sensitivity Quotient, or MSQ. The target here looks a little different. We are actually hunting for a 50% reduction in symptom severity by that 6-week mark. This specific metric is absolutely vital anytime you're prescribing habituation protocols, especially for patients dealing with persistent postural perceptual dizziness, or PPPD, post-concussion syndromes, or visual vertigo presentations.
Section 3. Recognizing clinical plateaus. Precise data is our best defense against subjective bias. Why? Because objective measures will detect a plateau way before your patients ever do. Look, it is incredibly common for a patient to come in and say they feel fine. Let's be honest, sometimes they just say that to get out of doing their habituation exercises. But the data doesn't lie. If their underlying functional deficit hasn't actually resolved, you'll know. If that FGA or DHI is just sitting static over consecutive reviews, that right there is your objective signal. It immediately tells you it's time to shake things up, change the dominant exercise category, shift the neuroplasticity mechanism, or crank up the context complexity by throwing in some dual tasks or busier visual backgrounds. So when you're working through those deficit-matched tracks like gaze stability, sensory weighting, locomotor training, or habituation, the real magic happens at the 4 to 6 week mark. That objective retest is the exact mechanism driving your next move. It completely removes the guesswork, telling you exactly when to advance the program, when to hold steady, or when it's time to switch the mechanism entirely because the outcomes are showing a clear plateau. Section 4. When to refer onward. Because we have to ask, what happens when you modify the dose and red flags start popping up? Here is where the data literally dictates your action. If you hit a hard plateau by 6 to 8 weeks, even after modifying the program, it's time to refer to a vestibular physician for diagnostics, like a VHIT or MRI. Are you noticing severe vestibular anxiety or agoraphobia? Bring in clinical psychology for CBT. In fact, patients with PPPD very often need an SSRI to complement the physical rehab you're doing. What if you suspect a vestibular migraine? You absolutely must co-manage that with neurology, because lifestyle and pharmacological prophylaxis change literally everything about how they'll respond to your VRT program. And crucially, sudden hearing loss or pulsatile tinnitus is a massive red flag. No questions asked, that requires an urgent ENT referral, not more rehab. When it comes right down to it, a carefully retested baseline tells the entire story. By identifying the lesion category early on, you can easily differentiate a stable peripheral hypofunction that is ready for some aggressive progression from an active, unstable lesion that needs cautious deferral and urgent medical review. Those objective numbers do incredible heavy lifting. They drive those onward referral pathways, and they secure profound patient buy-in. It's a whole different ballgame when your patients can actually see the hard data supporting your clinical decisions. Section 5. Vestibular Series Wrap-Up. This core message just beautifully wraps up our entire 4-part explainer series on vestibular rehabilitation therapy. We kick things off by exploring the 4 mechanisms of neuroplasticity: adaptation, substitution, compensation, and habituation. Then we move through the nuances of careful patient selection and deficit-matched exercise prescription. And today, we've firmly established the golden rule. VRT must be dose-graded, it absolutely has to be titrated to provoke mild to moderate symptoms to create that necessary error signal, and it must be rigorously retested at 6 weeks using published MCIDs. It has been absolutely fantastic exploring this evidence-based material with you. When we actually treat data as the true hero of our clinical practice, we ensure that every single 6-week program wraps up with a defensible, life-changing result for the patients who need it most.
Thank you so much for watching. If you want to dive deeper into dizziness, vertigo, and imbalance topics, or access the full literature review along with the super helpful clinician and patient cheat sheets, make sure to visit AustralianDizzinessClinics.com. And please, remember to subscribe and leave a rating. So, I'll leave you with this one thought as you head back into the clinic tomorrow. Are you still just guessing your patient's progress, or are you finally ready to let the data drive?